Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from F. Hoffman LaRoche Limited.
This program is presented by Medscape Education Global.
Hello, I'm Solange Peters, Professor of Oncology at Lausanne University Hospital in Lausanne, in Switzerland, and I would like to welcome you all to this program titled Targeted Therapies for Non-Small Cell Lung Cancer. Where are we today? Very large question. We'll try to answer that together with my colleague Ben Solomon, who does an introduction, but he's a professor at the McCallum Cancer Centre, Peter Mac, in Melbourne, Australia. Welcome, Ben, and very nice to have this discussion with you.
Fantastic to be with you, Solange, and we have a lot to talk about because there's been so much progress with targeted therapies for lung cancer.
So let's immediately deep dive into that. We have been revisiting, or at least updating the ESMO guidelines, living guidelines for advanced metastatic non-small cell lung cancer, including, of course, a chapter of non-oncogene addicted non-small cell lung cancer, and another manuscript separated nowadays for oncogene addiction because it's too much data, too many trials to cover. So what I mean by that is we'll focus today on oncogene addiction, and we'll focus today mainly on the examples which guided us through the journey of defining the best strategies. And I think there are two slightly different. It's EGFR and ALK. So I think that's probably something and a model which can be applied to the rarer and other oncogene addictions and other oncogenes. And we'll probably focus on them too, but of course, maybe we'll just evoke other opportunities. And here you can see on the screen the ALK algorithm about how to treat non-small cell lung cancer. So let's start with ALK, and I will immediately show this table, which is the summary of what every oncologist should be aware of in terms of defining the best frontline strategy for advanced metastatic ALK-positive non-small cell lung cancer. So maybe, Ben, you want to guide us rapidly and fast through the most important messages through these four important trials which define new standards of care in ALK addiction.
Yeah, absolutely, Solange. And first, I'd also like to echo your comments about the ESMO guidelines. I think they're a fantastic reference source to really get updated information. These are living guidelines about the data and how we should be treating our patients. And I think the ALK space is an area where we've seen a lot of change, and it's very nicely summarized in these tables. We have great options. We have at least 5 different targeted therapies that are available around the world. And I think when we have these choices, it's really important to have a knowledge of the differences between these agents in terms of efficacy and toxicity. And I think the main points that I would like to draw out as we've had these newer generations of ALK inhibitors, we have seen increased efficacy, and this comes in terms of increased efficacy, particularly in the brain, which is important to control in patients with ALK-positive lung cancer who frequently have brain metastases, but also increased efficacy in terms of ability to overcome mutations that cause resistance. And The top two trials that you see, the ALEX trial and the ALTA-1L trial with alectinib and brigatinib, I think really set a very high benchmark in terms of what we can expect with these agents, with progression-free survivals in the order of 2 to 3 years with these drugs, and excellent responses in the brain, and with very good tolerability of these agents. But in the last couple of years, we've also heard the update of the CROWN study with the third generation inhibitor lorlatinib. And we've seen really unprecedented results in terms of efficacy, with a median progression-free survival that has exceeded 5 years. And I think it'll be of great interest to see what the median PFS pans out to be, but regardlessly, it shows how we're moving with these agents. But something we also do need to consider, Solange, is the tolerability of these agents, because we know that these different agents have different toxicities. Alectinib, for example, has its own toxicities, and lorlatinib has a unique set of toxicities, I think, which we need to be aware of.
Yes, I fully agree. I think we are, with this oncogene addicted field, we are revisiting one principle that I was taught 20 years ago when I started oncology by kind of a little conservative old oncologists who were telling that first you look at efficacy. If the PFS and the OS are meaningfully, significantly improved, then you can look at toxicity. But nobody looks at toxicity before efficacy. So it might still be the case, right? Meaning that if you have a very high magnitude of improvements in EFS, DFS, PFS, and overall survival response rates too, then comes the reason why you should learn how to manage toxicity or not. And it's quite interesting because we'll discuss EGFR later on, and this idea of really having a kind of a better mixed appreciation between the duration benefit in terms of outcomes and the toxicity is probably quite modern and contemporary, right? To really try to refine a little bit the choice we make with the patient regarding not only survival, but also toxicity. And lorlatinib is the paradigm for that to me, because in the first time you presented this trial of CROWN, lorlatinib versus crizotinib, and this was coming after the definition of ALEX and ALTA-1L, meaning that we had better than crizotinib already. We had alectinib, brigatinib with fantastic results, very good tolerance to the compound, by the way. So our colleagues and even myself, we were a little kind of frightened to bring in a compound which is characterized by different and a higher grading of toxicities. And these toxicities are very specific, right? Lorlatinib give a perturbation in the lipids, right? Hypercholesterolemia, hyperlipidemia. It gives rise to weight gain, which can be annoying over time. It gives rise to some neuropathy, and it gives rise also to, I would say, never met CNS side effects, which can be about the speech, it can be cognitive, but it can also be the mood. So things that as oncologists, you are not completely handling with ease. So all of these toxicities were kind of questioning us about, is it worse taking these toxicities and the PFS and OS benefit versus alectinib? And I think time after time, data accumulating, we have learned how to deal with this toxicity, or we are still learning. And more than that, the magnitude of benefits defines really today, I would say, a scenario in which, if the patient accepts, we would like to manage the toxicity with him, right? Because it really defines a longer PFS. I will let you tell us about the 5 years data, but it's important to know that alectinib will present at the ESMO meeting the final overall survival data. And nobody will be surprised that if you start with alectinib, brigatinib, it's going to be years of survival. But what would be even more interesting for the patient is how many years can he stay on the drug without progression, without brain mets, without bone mets, without new lesions. And here, lorlatinib defines a new long-term progression-free survival, which is absolutely astonishing. Do you want to tell us a bit more about it?
Yeah, absolutely. And I will echo your comments about the alectinib long-term survival results, which I'm really excited to hear about and will be hearing later this year, because I think that reflects how we really have transformed the trajectory of disease with these highly effective targeted therapies. Who would have thought a decade ago or 2 decades ago that we would have lung cancer patients living in excess of 5 years, in excess of 10 years, but they do with these drugs. And, we talked about general principles in oncology. And one thing I think we keep coming back to is that we do need to use our most effective treatments first to give our patients the maximum chance of benefit. We can look at this in terms of a biological perspective, looking at reducing clone burden from the beginning. We can look at it from a practical perspective because we know that 25 to 50% of patients don't get second-line therapy. So it's really important for us to really choose our first-line therapy effectively. I also would like to echo the wording you used. You talk not just about toxicity, but about us learning to manage toxicity. And I think that is the key with lorlatinib, because a lot of the toxicities that we see are manageable, and the CNS side effects in particular do respond to dose reductions. And we know that this doesn't seem to impact efficacy. But getting back to the 5-year survival, so lorlatinib, we know, is a highly effective agent, very good at getting into the brain. But I think we were all surprised when, even at the 5-year update with lorlatinib, we saw that 60% of patients had not had progression. So this is what you were talking about earlier. Patients who had been diagnosed with lung cancer, even after 5 years, have not even had a bad CT scan or an MRI scan. Their disease remains controlled, and they're able to continue functioning as per normal. And I think sometimes people trivialize PFS curves, but progression for patients is a devastating event, particularly when it occurs in the brain. And having drugs that can prevent that from happening, I think, is fabulous for patients.
Okay, so I think we need to switch to have a kind of an overview and maybe to switch to the first, I would say, concept that we could create in terms of precision oncology, which was a discovery like 10 years ago of the EGFR mutation by our friends and colleague from Dana-Farber and 2 groups together, and just defining how a target can be targeted in lung cancer. So to go back to EGFR, we also have been going through a first generation of EGFR tyrosine kinase inhibitors, a second generation, which, by the way, we will agree have appeared and disappeared a little bit from the pipeline, and a third generation, which probably today define the new standards of care. This is the ESMO guidelines. The third generation we have in Europe is osimertinib. But across and around the world, particularly with the development in China, there's other quite equivalent third generation EGFR TKI. It's important to tell that because you might have to read these names, but just look what they are, because they are very good EGFR TKIs of third generation, which we don't have access to, but defines the same treatment strategy. But more than that, when you think about EGFR, we have been showing exactly like with ALK that giving osimertinib is better than giving a first generation. So that time it's not alectinib, lorlatinib versus crizotinib, but this is osimertinib versus erlotinib or gefitinib. It was the FLAURA trial. Better PFS, better overall survival, better brain control. So everything is better using osimertinib. So the same story in EGFR and in ALK. But the story has become more complex today, because we were not just satisfied by osimertinib frontline, which, by the way, does not define the PFS and an OS like lorlatinib. It has still always be something shorter, right? Something more frustrating. And we have been developing new strategies, right? So not only osimertinib frontline, but new ideas. Do you want to tell a little bit about it to start, Ben?
Yeah, so I mean, and the FLAURA trial, which established osimertinib as a standard of care, like you said, showed unprecedented efficacy, brain control, but also this is an unusual trial in that toxicity was actually less with osimertinib than with the first generation inhibitors. But then we've got these 2 trials which we see at the table, which really have looked at trying to improve efficacy further. One is the FLORA-2 trial, which combines chemotherapy with osimertinib. And the second one is the Mariposa trial, which combines one of these other third-generation inhibitors that you mentioned, lazertinib, with a bispecific antibody called amivantamab, which targets EGFR and MET. And both these studies showed improved progression-free survival compared to osimertinib, improvement of in the order of 23 to 25 months compared to 16 to 18 months. But what we've also learned is that we heard in Paris this year at ELCC the overall survival results from the Mariposa study, where there was a significant improvement in overall survival. And I'm very excited because we'll be hearing the overall survival results from the FLORA-2 study, which will be presented later this year at World Lung and also at ESMO, which also show us survival results. So this is really challenged our thoughts, Solange, about how we choose first-line therapy. And again, we have this balance of efficacy and toxicity. And I guess my question to you, Solange, is the toxicity profile is very different with the three regimens, osimertinib alone, FLORA-2, and Mariposa. And how do you weigh up this toxicity versus efficacy? And improved survival is very hard to argue with, right?
Yeah, absolutely. It's quite counterintuitive to go to these combinations, because I remember how much we've been promoting FLAURA in the past, right? FLAURA was an improvement in all the parameters, as you said, but also specifically, we could get rid of this EGFR class of drug side effects and toxicity profile, which we hate, which is about the rash, which is about the GI toxicity, a bit of gastritis, a bit of paronychia, so something that was impacting the quality of life in terms of being visible for the patients going out of their house. So we are so proud because of this therapeutic window, which was better for osimertinib to be able to give osimertinib monotherapy. And now we start again with combinations, right? So just to look at both FLAURA-2 and Mariposa. Mariposa, we go back to the EGFR class, EGFR inhibition class of toxicities. So keep in mind that you have this amivantamab, which is a bispecific. It targets EGFR and gives rise to rash, to GI toxicity, to paronychia. So all these side effects that we are so happy to get rid of, you will see them again. So it's important to keep it in mind, because for us, it might be felt a bit like, in terms of quality of life, a little step back. But again, as you said, the idea is the improvement in survival and PFS. So both of this trial, and probably even more than the story of lorlatinib we discussed before, questions this very, I would say, refined balance between living longer and living better. And both of the trial will show a benefit in survival, undoubtedly of several months. We could see it through the conditional power and the interim analysis. They were quite similar. Mariposa evaluated maybe 10 months difference, so that's a large scale, even if the calculation is suspicious, but something like 10 months. So it means you have 10 months better survival. So are we is it mandated to propose it to the patient? In the old days, we would have said yes. 10 months survival benefit. Of course, you have to, that's your duty as a medical oncologist to present it. Maybe I agree. Maybe we should discuss the option with the patient. But we should also discuss in Mariposa that you will have the side effects. And in FLAURA-2, that you will have the chemo. And the chemo we know them way better, but the chemo has the usual side effect of chemo, which has a little bit increased by the addition of osimertinib. So we will have to discuss the patients that it's roughly 10 months better, but you have all of these side effects. But it's interesting, in the first time that we really discuss so much an overall survival benefit. Usually we are buying it with enthusiasm, 10 months, 7 months, 8 months. It's amazing, right? But now we refine our way to balance toxicity, quality of life, and efficacy. And it's an interesting movement, probably a good movement in front of patient advocates and patients' perceptions of what we do. But it's a new way to move.
Yeah, and I think one of the other things which makes it even more challenging is the nature of some of the toxicities. Like you described with single agent osimertinib, we got used to patients having a very good quality of life for the 18 months PFS. But with the Mariposa regimen, the new toxicities that we've never seen before, infusion reactions, thromboembolism, and really very difficult to manage skin toxicities with, scalp desquamation, terrible paronychia. But even those we're learning to improve. And I think this also raises the question, which I think we're struggling to answer, Solange. Is there a way that we can select a population of patients that might need the intensified treatment? Is there a group of patients we can identify that perhaps we can use a less aggressive approach? And Solange, people have looked in the trials at subsets based on brain met, ctDNA. Can we make any conclusion from these analyses?
Unfortunately not, to my opinion, because what we have been looking at and the data we have in these two trials, by the way, give us a firm conclusion about it. The type of mutation, exon 19 versus exon 21, the presence of absence of P53 concomitantly, the presence of absence of brain mets, the presence of absence of ctDNA at baseline, or disappearance of ctDNA rapidly over time. All of these factors that we know usually define the duration of survival. They define the duration of survival regardless of the arm of treatment the patient is in, meaning it's not predictive. It's not related to treatment. It's prognostic. So it means that you cannot at least use these factors to tell your patient, in your situation, really the benefit will be larger, because it's not true. In this situation, the benefit will be the same. But there might be situation, and I would take it in potentially a negative way, meaning maybe you don't need to intensify. In these patients who have probably a very long survival under monotherapy. So I think we can potentially define a group of patients with might not be need intensification because you suppose the duration of treatment or monotherapy will be long, or on the other way around, the patient with a terrible tumor burden, brain metastasis, something which really will not allow you easily to have a second line, which is usually chemo. But at least, again, this is the art of oncology, because we are piling up prognostic factors to make predictive decisions somehow, which is not statistically rigorous and brings us to manage many to multi-factor parameters and try to make a decision out of it. So I think the most important thing is discussion with the patient and having an idea if the survival of this patient should rather be 12 months or 4 years, depending on the multitude of prognostic factor. So maybe we can discuss the next line, because the amivantamab story is an interesting story because it was not only used in frontline. It can also be used later, which also defines maybe a shorter exposure in terms of time. But if you think about the ESMO guidelines, and there's all of these opportunities to give subsequent lines of treatment. Of course, if you don't use osimertinib frontline, then you should use osimertinib in second line, that's for sure, because it's as we said, better therapeutic window, better affinity, and better brain penetration. But now we struggle more about the idea that depending on what you give frontline, osi chemo, lazertinib, amivantamab, what can you give in second line? What we know in parallel to the Mariposa trial, we had this Mariposa 2 trial. So if you start with osimertinib only, you can give amivantamab when it's time for chemo, meaning the second line. So for me, it might be an option where I buy amivantamab with more ease in terms of obligation and emergency in terms of cancer biology, but also in terms of duration of exposure of this patient in that context. So that's something I would consider, and I consider sometimes in my center. Would you do the same?
Absolutely. I think One really interesting thing about amivantamab is it doesn't seem to care too much about the mechanism of resistance within the tumor and can work across multiple different mechanisms of resistance. So I think it is a very good option when it hasn't been used in the first line. I should actually, resistance is an interesting discussion as well, Solange, because we often do biopsies to help guide our subsequent treatment, and sometimes they can be informative, sometimes they don't help us, but I think it's something that we should think about. We also see, of course, the problem of small cell transformation, which requires a different approach. But it's also interesting that amivantamab seems to really reduce MET as a mechanism of resistance when given as a first line, and that I guess also speaks to how you think about second line really is conditional on how you've done your first line treatment. This is, and the ESMO guidelines I'm sure will be updated to reflect that, because these guidelines currently reflect just single agent osimertinib. But the landscape is becoming so complicated with, at least 3 potential first-line regimens. Now, in addition to the drugs we've talked about, where we're also seeing antibody drug conjugates that have efficacy. We've seen some provocative but not conclusive data about bispecific antibodies in combination with chemotherapy coming from China as well. And I think it's a great thing for patients that we've got lots of different options. But I think it's fair to say that the optimal the optimal sequencing is really not defined and is likely to be different from patient to patient.
And let's keep in mind really that whatever you do, defining what resistance you face is quite important. As you said, MET amplification, we don't like it because it very often defines an aggressive disease, but we have MET inhibitors, right? We have seen recent data about savolitinib, but there are 3 MET inhibitors, capmatinib, tepotinib, that you can also use in combination with EGFR TKI. The terrible small cell transformation where chemo is a standard but does not perform well. You have all these ADCs, datopotamab deruxtecan and other. And of course, as you said, there might be a role with chemo to give immunotherapy and anti-angiogenic, right? We have 2 or 3 trials, the Atlas, the one from this bispecific. So all of these are options that you need to look at your environment, what you have access to, looking at the tumor itself and looking at the patient preference at each moment. The more lines we have to sequence, the more options we also have to potentially prolong survival. But we also have to keep in mind that the small cell transformation and the brain disease are very often the bottlenecks we end up with at the end of the journey, right?
No, I was going to say, and I think, I think you said it before, the sort of, with EGFR, we still have a bit of a plateau of survival, which was 3 years now. It's been pushed a little bit further, maybe an additional, 8 to 12 months. But I think we've got, hopefully these new agents will push that boundary even further.
So I wanted to move because it's your field. All of this, we speak about ALK and EGFR. I think it's good here because if you speak about these 2, ALK and EGFR, we have also been moving all this knowledge in the curative setting, right? In the surgical curative setting, and we'll also cover also in the non-surgical, so definitive radiochemo setting for EGFR. But let's speak first maybe about surgery. If you perform surgery in this patient with EGFR ALK mutation, the main question we could more or less answer at the time being is there any role of these TKIs in the adjuvant setting? So maybe you can summarize that for us because you've been involved in both Alina Adara trial. What is the answer to that question?
So the short answer is yes, there's a role. And I think this was nicely shown, firstly, by the ADORA study. And, you talked about EGFR, discovery of EGFR mutations really setting the path for targeted therapies in lung cancer. And not surprisingly, EGFR targeted therapies have pioneered the path in early stage disease as well. And in the ADORA study, patients who had resected EGFR lung cancer who had adjuvant chemotherapy were then randomized to osimertinib for 3 years or placebo. And maybe not surprisingly, there was an improvement in disease-free survival, which was highly significant. But I think what was really, really important was that the adjuvant osimertinib improved overall survival. And at 5 years, the overall survival was improved from 78% to 88%. So a 10% absolute improvement in overall survival at 5 years. And whichever way you look at it, this is really meaningful for patients. We also saw things like reduced recurrence in the brain. And so this has really set standard of care. And not surprisingly, we saw similar findings with ALK-positive lung cancer with the ALINA study. Importantly, there were some different design features in the ALINA study. So in this study, patients who had resected ALK-positive lung cancer were randomized either to standard of care adjuvant chemotherapy or to 2 years of alectinib. Now, the study was positive in favor of alectinib. There was a disease-free survival benefit with a big hazard ratio, actually a small hazard ratio, but a big benefit of hazard ratio of 0.24. And we await more follow-up and survival data, but we expect that it would be translate to what was seen in the ADAURA study. And this really shows that there's a role for adjuvant targeted therapy. But of course, and I'm interested in your thoughts of this, Solange, there are lots of unresolved questions. And to my mind, the biggest questions are the optimal duration of the kinase inhibitor. It was 2 years in ALINA, it was 3 years in ADAURA, and also the need for chemotherapy. And I think these are questions which to my mind have not been completely resolved. And I'd love to hear your thoughts on these factors.
Yeah. It's quite interesting because when you use TKI, maybe on the contrary of immunotherapy, you probably have to biologically keep in mind that you are not going to really cure the patient with the addition of the TKI. At least it would not fulfill what we imagine from the biology. So at the end, you prolong survival, and for sure, alectinib will do the same thing as osimertinib in each of the settings. You improve survival, but I'm not so sure that in defining the cure rate, meaning cure means having a benefit very long term without any treatment. So how many patients are out of the disease for the lifelong, right? For the rest of their life. I'm not so sure you will modify it. I don't want to remove anything to the overall survival benefits. You live longer. But the idea of being curative might not be met using TKI or more curative. So what I mean by that is it's difficult to judge what is the best duration. The best duration will be the one prolonging more survival with an acceptable safety profile. I remember when you had the ADAURA, it was 3 years, and people were telling, but why 3 years? Why not 5? And why not less, just 1 year? When ALINA came, same question. Why only 2? Where we were. So it's really kind of it's supposed to be designed based on the rate of relapse in the previous trials and in the I would say real world data. But what I mean by that, it's a little bit random. The idea is how much can you prolong survival with how much toxicity, even financial toxicity in terms of risk benefit and economicity of what you do. So I think we have to keep in mind that we improve survival, but I'm not sure we cure more patients. But improving survival is of great value. So what I mean by that is I'm not so sure we will define the best duration, and intuitively I would probably tell longer is better. But of course, there are patients who would receive years of osimertinib being already cured. That's the charm of adjuvant, right? Some patients don't need anything. So I think the longer is the best, but we need to find a middle way with a good overall survival benefit and a sustainability over time. The second thing about chemo, I'm very conservative. And I think many colleagues are very conservative in the academic setting. Maybe not in a clinic where the pace is very fast and you need to make things simpler. But for me in ADAURA, this was not the question. Chemotherapy was not a question of a stratified randomization, meaning that no way you can judge about the utility of chemo. When you use ADAURA, you should give chemo to all the patients who respond their disease respond to the usual criteria for adjuvant chemo. For Alina, it's more difficult because the design was comparing that. But still, I believe in this curative, and here it's about cure, potential of chemo. You gain 5% long term. So even when I propose Alina, I like to, in the fit patients, give the chemotherapy before alectinib. Let me just go, because we are beyond the time which was allocated to us. Let me just go to this slide, which is just telling, it's one message. It's just telling that there are other oncogene-addicted non-small cell lung cancer, which are the subject today of ongoing clinical trials. I like, for example, the example of selpercatinib, an extremely rare alteration, the RET rearrangement in the adjuvant versus placebo. It's unbelievable that it might complete accrual and go to the final reading at any time. And we have been learning also that the HER2 mutated have the same kind of adjuvant. So 2 questions here is, we know what we will show probably, provided the drug is well tolerated, provided the drug is efficacious and goes to the brain, which is the case of selpercatinib and of these HER2 TKIs. So provided that we know the results and we conduct the trials for hundreds of millions, so will there be a point where we can apply a strategy rather than spending money and revisiting the equipoise, right? Because if you know the result, you should not randomize in a better manner. That's my main question point. I'm not so sure we're getting there. What do you think, Ben?
Yeah, I too have this question. I think all these trials will be designed with disease-free survival as an endpoint, and you can almost tell before the study starts that it will meet its endpoint. And, you know, we talked about RET and HER2, and I believe there's even a trial in ROS1 that's being planned. And I think I think we are in a position where we can extrapolate with a fair bit of confidence that these agents will work in that setting. And we had a little bit of discussion about this earlier, but if we know the drug is very effective in prolonging PFS, if we know it's very effective in controlling disease in the brain, it's very likely to work in this setting, just as alectinib and osimertinib have. And maybe there's a way that we can save our society from all these many millions of dollars from doing these trials.
Thanks so much. So basically, I think we've gone around EGFR and ALK more at principles of defining strategies in advanced disease, in early disease, combinations, sequential treatment, moving back or moving forward to early disease.
It's always great to talk with you, Solange, and there is so much exciting data to talk about, and I'm very much looking forward to our next few meetings, World Lung and ESMO, coming up.
So that being said, Ben, I would like to thank you for this wonderful discussion. I think we are all looking forward for some new data to come through the next big conferences, right? I would also like to thank you all for participating in this activity. Ben, a little words to close the session?
Yeah, no, thank you, Solange. Always great to talk with you. And it's just fantastic seeing how much new data we have. Our decision-making is more complex, but I think the important thing is that this really does mean that we're seeing more options for our patients, and that has to be a good thing. Thank you so much.
Yes, and please continue on to answer the questions that follow, and please also complete the evaluations. Thanks to all of you. Thanks, Ben. See you soon.
This program was presented by Medscape Education Global.